Hi everyone, so myself Dr. Kumar Gaurav and the topic for today is Keratosis Obturans. So what is the definition? Well, it is the accumulation of the desquamated keratin in the external auditory meatus. Here you can see this is the collection of the desquamated keratin in the EAC, hence obstructing it. So what's the pathology? The keratin squames are shed from the complete circumference of the deep ear canal, forming a lamina, and geometrically patterned keratin plugs within the lumen of the expanded ear canal. Normally the epithelium from the tympanic membrane, it basically migrates to the posterior meatal wall, and failure of this migration or obstruction to the migration by wax or the foreign body causes this keratosis. Well, there are various types, and first is the silent type. There is no predisposing acute infection involved, and it caused by the abnormal separation of keratin and persist even after removal. So this is the silent type. Then comes the inflammatory type. It is due to the acute inflammation of the ear canal, and the pathology is caused by the increased epithelial turnover and alteration of the epithelium migration. So there is a increased epithelial turnover and alteration in epithelium migration. So now here you can see the primary cholestoma of the EAM. Primarily what happens, there is an irregularly erosion of the bony wall, post-traumatic or the post-surgical. So what happens, this squamous epithelium, it invades the bone. So what are the clinical features? The pain, plurulent otorrhea, but there is no conductive hearing loss. And subjective to histopathology, to rule of the carcinoma or the necrotizing otitis externa. Here you can see this is a neglected Keratosis Obturans, which further lead to the cholesteatoma of the ear canal, and it's lead to the erosion of the bony wall of the EAC. So what are the clinical features? There is severe ear pain. There is a mild to moderate conductive hearing loss associated with the bronchiectasis, sinusitis, and primary ciliary dyskinesia are common, and rarely otorrhea is present. Well, in examination, the canal is occluded by a plug of white keratin debris which contain a small amount of normal appearing brown cerumen in its center. There may be accompanying granulations with the widening of the external auditory canal. Well, if you do the CT scan, the images of the temporal bone will show widening of the external canal with the bone erosions. Well, if you talk about the management to treat the cause, the impacted wax syringing can be done. In inflammatory type, to treat the infection, the foreign body instrumentation, and well, use of the keratinolytic agents like the 2% salicylic acid and alcohol can be used. Well, we have to go for a surgery like mastoidectomy in patients with the primary cholesteatoma of the external canal, because it has eroded the bony wall of the canal. So we have to go with mastoidectomy surgery, and well, removed specimens should be sent for the histopathology to root out the malignancy. Thank you guys. Do subscribe my channel for more videos.